Now, when we say capnography, what do we mean? What is it?
Well, it's the same thing. The other name for it is end tidal CO2, meaning that what we're breathing out. We breathe in oxygen, our body takes it in, and we breathe out carbon dioxide, which is the byproduct of what our body took in. So with that, when we breathe out or exhale, the device that have or capnography is able to detect produces a number and a waveform, and with the two, you can determine potentially how sick a patient may be. For the airway, if you put in advanced airway, you'll see a particular waveform and or a particular number depending upon where the patient may be as far as how sick they are. All I've done is research the research and put together, I just authored a book this past year as well on capnography to hopefully pass the information on to others of what we can do to hopefully save lives and decrease length of stay for patients.
Now, obviously, every patient is different, every case is different, but with an assessment like this that's non-invasive, how much does it change the order of care or the procedure of care?
Well, it just moves the care is recognized and bring to the attention of the healthcare provider. For instance, if a patient's on the floor and we start seeing, even though their blood gases, the blood work they drew is perfectly fine the last time they did it, they need to have a red flag to justify it. And the Sepsis Alliance, they look at the 1 hour bundle, meaning that to get started in 1 hour, but the patient has to show a temperature, the patient's heart rate has to be increased. All these things happen to take place. Well, capnography can go ahead and look at the trends that are happening because it's a tool that doesn't lie. I mean, as we breathe out, it's telling us what our body metabolizes. That's it. Just like our heart rate, whatever it may be. But it's red flagging. The data I have, because I have about a binder that has about 70 cited research areas that I've gotten, it has come to the the most vital of vital signs coming into the emergency room to determine how sick a patient is or whether they end up in the ICU or deceased is capnography. It's more superior than a blood pressure, a pulse, a temperature, or the SaO2, the pulse oximetry they put on the finger. So it's like, why don't we use something to red flag us and getting patient care for that patient? Because we don't know where the patient's at as far as the point of no return, to where now, no matter what we do, all the antibiotics, all the things we throw at them, are they going to survive the outcome of their sickness they have? What comorbidities they have? So this device here is just a very underutilized assessment tool that should be used, in my professional opinion, for all patient care, to where we catch patients and we're decreasing the readmissions. We're decreasing the people that may be dying, the number of folks that die from getting sepsis from within the hospital. I mean, we're not going to stop getting sepsis or getting the sickness, but if we red flag it early and we get the antibiotics on, we're warding off what goes on.
You talked with sepsis, there's obviously these boxes you got to check to make sure that that's what it is. Takes time. This is obviously, from what I'm understanding, a much quicker way to assess that. Is that what you're seeing, and how much time can it save, in a manner of speaking?
Well, if it's in a hospital, it's once I start seeing trending, I realize at that point I need to get with the doctor and then go ahead and follow through with getting blood work, potentially getting it back, having it evaluated to see what is the cause of it. Is it something in the kidneys? Is it something in the blood sugar? Is it something that they're developing an infection? I mean, the number one cause of altered mental status in geriatrics is a UTI. So, I mean, and if they're in a nursing facility, if they're in an assisted living facility, it's common for them to get it. My goal is that why don't we even utilize it in a nursing home or assisted living facility? When we go around and take vital signs, they have this little nasal cannula type thing that belongs with them. We got one device that goes in every room. And we look at trends. Because then what we could do is potentially, from that aspect of it, we're seeing something going on to where we're not transporting the patient out to the hospital. They're not going to a hospital, potentially getting sepsis in the hospital or getting MRSA. We're treating them in the facility, where the facility is not going to lose any money. And now we're treating them and we're taking care of them to where they're staying there probably closer to home versus in a rural area to where they may be transported out to another facility. Now, how's the family going to go see their loved one?
Right.
So by keeping them there, everybody wins out. And more so the patient does and the family.
Now, once again, kind of sounds like a time-saving assessment, something that could potentially save lives, or like you say, shorten a patient's stay within the hospital. Why are more hospitals not doing this, and why is it not being utilized? I know the way you would like to see it utilized.
I don't fully have the answer. We rely a lot on technology, meaning that the blood gases, we have that. And we rely on, some hospitals have systems. They have electronics like the data. So we input the data here, and then we get it out, and it looks at trends and say, hey, this patient may be getting septic or sick or whatever it may be. The key about that, there's two problems with it. One, it's only as good as the person inputting it. And secondly, it's only as good as the person reading it. If there's a failure of anywhere there, the patient has failed. Something we're doing probably every 4 hours, every time the patient's in a facility, is taking a set of vital signs. If we use and incorporate end-tidal or capnography in with that every 4 hours, we're going to see a lot earlier trends that are taking place before any blood work or the obvious, like the temperature start, the blood pressure drops. All these things that may take place later on with depending upon the disease or the, I should say disease, the illness that which they're suffering from.
Now, you've been here at Melissa Memorial Hospital this week teaching the staff and the EMT department this process.
I have. This is my third time here. I got involved with Holyoke, the CEO, Mr. Mike Castle. Back in the day, he was one of my paramedic students, and I had the luxury of teaching him, and he has since educated himself, moved up through the ranks to become CEO of a hospital. I reached out to him when I had put all this together. He says, come on up. I came up. The folks here were very receptive, I tell them they're like sponges to me. They want to learn, regardless whether it's too advanced for them or whatever, but they're still sitting there taking down notes, doing and it makes coming here teaching really, to me, worthwhile. I love it. Because if they're there willing to absorb it, even though they're being voluntold to be there, and they have the attitude, well, I'm going to make the best of it, and I'm here taking notes, it really gives a shot in the arm of wanting to instruct them.
Obviously, nurses, EMTs, paramedics all go through a lot of training, but this is something that they don't have to spend weeks, months learning.
No, the course, I'm here, I give a consolidated version, just 1 hour. Typically, the entire course, as far as the pre-course assessment, post-course assessment, the instruction, it typically takes close to 3 hours. The time I was here before I had done the entire course, we had, I want to say, 5 of the physicians sit in on it. Got great feedback from them, and hopefully they're still utilizing it today.